Hello, this is Spencer, oncology pharmacy resident, and for this clinical pearl, I'll be talking about oral chemotherapy management for inpatient orders. The reason why I've picked to talk about this topic is because oral chemotherapy is becoming more and more prevalent. To date, there are now more than 100 different oral chemotherapy medications on the market. There are new medications continued to be developed. In 2020 alone, we already have 2 new oral chemotherapy medications, one for epithelioid sarcoma and one for gastrointestinal stromal cancer. In 2019, there were 6 approvals, and then on top of new medications being approved, there are medications that are gaining new approvals. So niraparib, which was approved in 2017 for ovarian cancer, recently just gained a new indication in ovarian cancer maintenance. With the number of new medications being developed and current medications gaining new indications, it's more than likely that you'll run into a patient who is on oral chemotherapy, and those numbers may increase. To show the advances in cancer and oral chemotherapy, I just wanted to take a second to go through sort of the history of medications being approved by approval date. So in 2018, we can see an extensive list here of different medications. In 2017, there were slightly less. In 2016, only 2. In 2015, again, there was a little bit of a surge. And here we have the medications for 2014, 2013, and 2012, 11 through 07, 06 to 99, 98, and then back to 1953 with 6-mercaptopurine. Though many cancers now do have oral agents, here is a list of the most common cancers that use oral agents, with the greatest use being seen in non-small cell lung cancer, multiple myeloma, chronic myeloid leukemia or CML, as well as prostate, breast cancer, renal, hepatocellular, and ovarian. So the biggest things to consider when there's an order that comes through for oral chemotherapy for an inpatient: number 1, is it possible that the oral chemotherapy agent is the cause or contributing factor to the reason for admission? Number 2, are there any expected procedures, surgeries, or tests that the oral chemo agent could adversely affect? And number 3, why is the patient on the oral chemotherapy agent? Is it for cure or for palliation of metastatic disease? That could factor into getting that order verified immediately, or taking the time to consult the managing provider to see if this medication is truly needed while they are admitted. Getting into now the reasons to hold therapy or possibly dose adjust the medication. Here are some events that could warrant an admission that are most likely due to an adverse event of the oral chemotherapy agent. So as we can see, infection or hematologic toxicity or bone marrow suppression. Really checking to see what their ANC level is, as well as looking out for thrombocytopenia, as well as anemia. Many of these medications could also cause thrombotic events, as well as extensive uncontrollable diarrhea. There is mucositis, rash, kidney injury, as well as liver injury, neurologic toxicities, and then one last reason to hold the agents would be for any upcoming surgeries or procedures. So determining to continue oral chemotherapy. So here we have some tools listed to help in the verification process. The resource that I prefer to use is Lexicomp, and within Lexicomp I'll look to see if there's any black box warnings. If none of the black box warnings match up with why the patient is being admitted, then I'll move to dosing and look at the adjustments for toxicity to see which toxicities are commonly experienced and would require either dose adjustment or holding of the medication. After looking at the adjustments for toxicity within the dosing of the medication, I then look to the common toxicity criteria within Lexicomp for oral chemotherapy medications. All oral chemotherapy agents contain common toxicity criteria within Lexicomp, which can be found within the Related Informations tab. After looking at the common toxicity criteria to see what events the patient could experience, I then look at the adverse events section and the patient and therapy monitoring. At Monument Health, we do have oncology pharmacists who are available Monday through Friday from 8 a.m. to 5 p.m. who are able to help with the verification process for oral chemotherapies, which are continued on the inpatient side. So any of the pharmacists who are not 100% comfortable with verifying oral chemotherapies are able to reach out for assistance. I would recommend, if you do have those resources, to try to utilize them to the best of their ability, because oftentimes if there is something that is urgently needed, they are most likely able to get to the provider quickly. Oftentimes when patients are admitted, there will be new medications that patients are started on, and so it's important to look out for any new drug interactions. With our EGFR inhibitors and BCR-ABL TKIs, there is an interaction with proton pump inhibitors as well as H2RAs and antacids. So the medications that we are looking out for are erlotinib, gefitinib, dacometinib, nilotinib, dasatinib, and bosutinib. This is a major interaction in which the proton pump inhibitor and H2RA reduce the amount of drug that is being absorbed to the point where it could really affect efficacy of the medication. Another interaction is capecitabine and warfarin. So there's a capecitabine patient who comes in with a new DVT or PE, and they're started on warfarin. Always be cognizant of that interaction. An abundance of these oral chemotherapy agents are also CYP3A4 substrates, so looking out for any new CYP3A4 inhibitors or inducers. And then our last interaction to really be looking out for if a patient is coming in with an infection and they are started on fluoroquinolones. Many of the oral chemotherapy agents do also have QTc prolonging effects. If alternative therapy can be given, it would be in the best interest of the patient to do so. Moving along to our first medication class, so we have tyrosine kinase inhibitors. So here's a just depiction on how tyrosine kinase inhibitors function. On the left, we can see the normal cell function where a growth factor attaches to the receptor and the tyrosine kinase starts the signaling for cell division. The signal travels to the nucleus and the cell undergoes division. On the right-hand side, we can see how TKIs work. So there's still that growth factor attaching to its receptor, but the tyrosine kinase inhibitor stops that first signal for cell division from occurring, and the cell doesn't go on to further divide and replicate. Within the TKI broad class, there are vascular endothelial growth factor inhibitors, so medications like axitinib, cabozantinib, pazopanib, and sunitinib. The major adverse events caused by these medications, which would require holding of therapy, would be hemorrhage or VTE, as well as hepatotoxicity or reversible posterior leukoencephalopathy syndrome. Within the list of adverse events, we could also see impaired wound healing or wound healing complications. And so this is really where if the patient has any procedures upcoming, we would want to hold the VEGF inhibitor prior to procedure and then post-operatively. Our next TKIs are the epidermal growth factor receptor inhibitors or EGFR inhibitors, erlotinib, lapatinib, afatinib, gefitinib, and osimertinib. These medications are mainly used in non-small cell lung cancer, and the adverse events that would require holding would be from cardiovascular events or hepatotoxicity. These medications are also known to cause GI perforation, as well as they are QTc prolonging. Moving along to our BCR-ABL tyrosine kinase inhibitors, which are used for Philadelphia chromosome positive chronic myelogenous leukemia. So the agents we have here, ponatinib, bosutinib, nilotinib, and imatinib. The adverse events that we really want to look out for and make sure that the therapy is being held if a patient is experiencing would be bone marrow suppression, fluid retention, or edema, especially with the use of bosutinib. Again, GI perforation, they are QTc prolonging, and can cause some severe hepatotoxicity. Next, we have the ALK inhibitors or anaplastic lymphoma kinase inhibitors, which are used again in lung cancer. So we can see alectinib, ceritinib, crizotinib, or leratinib. Their adverse event profile is much less than the previous TKIs, but still looking out for hepatotoxicity as well as pneumonitis, and they are QTc prolonging. Here we have a couple of miscellaneous tyrosine kinase inhibitors. So for the BRAF kinase inhibitors, vemurafenib, dabrafenib, and encorafenib, mainly looking out for dermatologic toxicities or any new onset of skin cancers as well as hepatotoxicity. For the MEK inhibitors, binimetinib, cobimetinib, trametinib, looking out for extensive rash as well as diarrhea and possible peripheral edema. For ruxolitinib, the Janus-associated kinase inhibitor, the biggest things that we're looking out for are cardiovascular toxicities and hematologic toxicities.